I'm Marcela Bonvalez, president of Weinstein Imaging in Pittsburgh, Pennsylvania, which is a private practice specializing in women's imaging. I will be speaking on Birads for ultrasound today. Today I'm going to be talking about Birads for ultrasound. These are my disclosures. Birads Atlas 5th edition came out in January 2014. The Atlas, the chairman of the committee was Dr. Dorsey, and the committee was divided into 3 subcommittees. One in mammography, which was the 5th edition. Dr. Sickle led that committee, and then Dr. Elizabeth Morris led the MRI edition, 2nd edition. The ultrasound 2nd edition was chaired by Dr. Ellen Mendelsohn. Dr. Mendelsohn, Dr. Berg, and I were the writing committee. BIRAD stands for Breast Imaging Reporting and Data System. It's a practice management system developed for imaging containing several important components. 1, a lexicon of descriptors for feature analysis of breast lesions. Also, a reporting structure which includes final assessment categories and management recommendations. In addition, it's a framework for data collection and auditing. The BIRAD structure contains different chapters. 1 in anatomy, another image quality, tissue composition, feature analysis, the lexicon, which includes masses, calcifications, associated features, and special cases. It also includes a part in reporting systems, guidance, frequently asked questions, and there's an appendix. The additions and changes from the previous edition include the discussion on density limitations of mammography, the need of correlation with ultrasound depiction of tissue composition. There's been an increase in the anatomy section. There's also now a new section about associated features, which includes the effect of lesions on surrounding tissue, architectural distortion. Also includes vascularity and elasticity assessment of the lesion. There's expanded the importance of image quality and accurate interpretation has been expanded. There's guidance and frequently asked questions. This section has also been expanded to include screening considerations and the need for audit. As we know, there's been a lot of talk recently about breast density. The radiologists need to discuss the need for the radiologist to discuss the breast density and its implications to increased risk of breast cancer. And here in a mammogram, we know very well that breast density has been divided into fatty, B, typical scattered breast density, heterogeneous would be C, and D, a very dense breast. Mammography is very limited in those patients with a very dense breast compared to those patients with a very fatty breast. Ultrasound can also determine the tissue composition of the breast. As in this case, you can see a medial light projection of a mammogram showing a very dense breast, correlating very well with this ultrasound, adjacent ultrasound perpendicular projections. You can see that the skin layer is seen through echogenic lines, separated by a hypoechoic area. Beneath that is a subcutaneous fat, and then you see very echogenic tissue with tubular hypoechoic structures which represent ducts. This is a typical case of a homogeneous fibroglandular tissue breast. Also, the breast could be homogeneously fat, and this is a good example showing which is composed of uniformly of hypoechoic fat lobules and echogenic tissue arcs, which are the Cooper's ligaments. Or we could describe the tissue as heterogeneous, and that's either focally or diffusely variable in echotexture, with many small areas increase and decrease echogenicity. And here on the mammogram medial light projections, you can see a heterogeneous breast density in which there's areas of fibroglandular tissue and areas of fat, corresponding very well with the adjacent ultrasound study showing the subcutaneous fat, and then an area of echogenic tissue. Within the echogenic tissue, there's hypoechoic areas, which is fat within the fibroglandular tissue. We've increased the section, we've made it much more descriptive, the area on anatomy. And the breast is described as a modified swept gland between two layers of superficial pectoral fascia on the anterior thorax between the second and sixth ribs. The posterior fascia layer lies just anterior to the pectoral muscle, and the anterior fascia layer lies just beneath the skin. The breast is made up of 15 to 20 segments of major ducts and branches. The lobules radiate from the nipple and subdivide into lobules. Subcutaneous kinetic tissue from septa, the Cooper's ligament between the lobes and lobules, which go from the dermis to the superficial fascia, can many times be identified well with ultrasound. The nipple areal complex can be difficult sometimes to see with ultrasound unless we do certain maneuvers. For example, this is a normal nipple areal complex, can be seen well because abundant gel was placed between the nipple and the transducer. Here we see nicely that the nipple is seen as a hypoechoic, circumscribed mass. And the skin layers are well seen here, two echogenic layers separated by hypoechoic area. But important here is that we can see very well, by using this technique, we can use very well, you can see the area behind the nipple. When you don't use gel or you don't use an offset pad, many times the nipple can cause posterior acoustic shadowing, obliterating visualization posterior to the nipple. The new automated breast ultrasound units also are very helpful in visualizing the nipple areal complex and the tissue posterior to it, as you can see here. This is the coronal view. You see nicely the skin and the nipple, and here are the perpendicular projections, and the nipple can be well evaluated. In contrast to this patient, which a lot of gel was also used to be able to visualize well the nipple, but in this case, the patient had a very enlarged nipple, and this was mucinous carcinoma of the nipple, a very rare process. The ducts can be seen by ultrasound as anechoic bands up to 8 millimeters wide near the nipple. They decrease in size distally to about 1 millimeter, and you can see the arborization here in these two ultrasound images. We've added a new section, associated features, and it's the effect of the lesions to the surrounding tissue. Includes architectural distortion, skin thickening, pulling of the nipple, and I'm going to show you a few cases of that. Also, the effect of vascularity in the lesion and elasticity assessment. The associated features include no effect of the mass, no effect of the surrounding tissue to the mass, or some sort of effect. Architectural distortion can be seen as disruption of anatomic planes, Cooper's ligament straightening or thickening, the duct changes in the caliber or arborization, skin thickening or retraction, or edema. In addition, vascularity. Is it present or is it absent? Is it in the mass or is it outside of the mass? And the effect in evaluation of elasticity. Here is a supine automated breast ultrasound unit image showing very nicely the cancer architecture. You can see a hypoechoic, ill-defined mass pulling of the skin. There is straightening of the Cooper's ligaments, and the adjacent, it's very well seen that there is associated surrounding effect to the tissue. Here on the lower left is a coronal view, which is a lateral coronal view seen here on this diagram, showing nice the spiculations of the mass, the effect it has on the surrounding tissue. The crosshairs here all correspond to each other, and you can see well that on this diagram that this mass this image was obtained in the left lateral projection at the time it is 2 o'clock, and the distance it is from the skin and the distance it is from the nipple. Another patient, you can see on the coronal view the little hypoechoic or actually spiculated mass on the coronal projection. When you put the crosshairs there, you see that the mass is an irregularly marginated mass with posterior acoustic shadowing, pulling of the Cooper's ligaments, thickening of these ligaments and pulling, and so there is definitely effect on the surrounding tissue. In addition, you can see that the mass is protruding into the ducts, invading the adjacent ducts. What effect the lesion has on vascularity. And here you have a very irregular mass, edema surrounding the mass. This is a suspicious mass. It's some enhancement, very suspicious. When we put flow, we see that there is increased blood flow not only to the mass, but in the surrounding edematous tissue. A different patient with only increased flow in the rim of the mass. The mass is well circumscribed, it's heterogeneous, and there's no flow within it. The flow is in the surrounding tissue, and this is an abscess. Elasticity is tissue stiffness, and it's really become the 21st century palpation. The expectation is that malignancy is hard and something benign will be soft. However, there is superimposition of both. There's two types. There's the strain and the shear wave elastography. And we still need to develop descriptors for these two types of elastography. Now we can also quantify the amount of tissue stiffness, which will help us and better determine if the lesion is hard or soft. And here in shear wave, you can see an example of blue is soft, and that's supposed to be benign, and hard is red. As you can see in this little image, there's lots of red and yellow surrounding this mass. And then there's a big range of cases that are indeterminate. And here are two different patients. Again, ill-defined on the B mode. You can see ill-defined hypoechoic mass with shadowing, irregularly shaped, and this looks like a cancer. And when you put the elastography, you see that there is very stiff tissue surrounding the mass. In contrast to this, on your right, a circumscribed oval mass parallel to the skin layers. Sonographically, it has all the characteristics of a benign lesion. When we did elastography, it corresponded well with blue. It was soft. The mass was soft. The adjacent tissue was soft. This would correspond to a benign and give you confidence that this does not need any further evaluation with a biopsy. Strain elastography, it's been described that trilaminar sign in patients which have debris-containing cysts, and here's a hypoechoic debris-containing cyst with enhancement posteriorly, and many times you can't tell in these cases if it's a debris-containing cyst or actually a mass. Well, they've described the trilaminar sign in which the three colors are seen: red, yellow, and blue, and this should help you differentiate debris-containing cysts from a cancer. However, I want to show you this case I had recently in which you see a irregularly marginated mass, hypoechoic mass. It is suspicious for malignancy. When we did the elastography, we got the trilaminar sign, which would lead us to believe that it was benign. However, because of the morphology of the mass, we biopsied it, and this was a mucinous carcinoma. So you need to be careful. Morphology is most important. We also have really expanded the section on the importance of image quality and accurate interpretation. We talk about the transducer frequency. Important to have a high-end transducer that's between 12 and 18 megahertz with a 5 centimeter penetration. The importance of gain and focal zone to differentiate a cyst from a solid mass. We also talk about the importance of knowing when to use compound imaging and when to use harmonics. The field of view, the depth setting of the tissue that will display on the monitor should not include the pleura or the lung. For large lesions, consider using an extended field of view, panoramic, or sometimes it's said to be called panoramic, or the trapezoid acquisition can be used in these large lesions. Important the patient positioning. Also avoid compression when evaluating with color to avoid occluding the blood vessels. Here we have two different we have the same patient with using a 12 megahertz and a 17 megahertz transducer. On the top, the 12 megahertz transducer does identify the calcifications within the ducts. However, the linear 17 better visualizes the calcifications within the ducts. Here's two images with the same cyst, and you can see that the tissue posterior to the simple cyst, it enhances brightly, but the refraction shattering at the lateral margins of the cyst obscures the adjacent tissue in this with a native mode. When you add the spatial compounding, you can see much better the margins of the cyst. Also, you can see the area posterior to the cyst, even though the enhancement is decreased with spatial compounding. So it's important for you to know that you should be able to go back and forth. Use spatial compounding when you may evaluating a cyst, and sometimes you may need to go back and use a native mode. Wide field of view. It can be very helpful in cases in which you have multiple cysts to try to see the relationship between one mass and the other mass. And this is the panoramic view that can be obtained with most machines. And here is the automated breast ultrasound unit showing very nicely a field of view that extends 14 centimeters. And so you can see multiple dilated ducts with hypoechoic material with it. It's also seen in the coronal projection here in this patient who had multiple abscesses. A mass. A mass is defined as something that occupies space and should be seen in two projections. Masses can be distinguished from normal structures such as ribs or fat lobules using two or more projections and real-time scanning. Its combined multiple features are the best predictors of a mass if it's benign or malignant. Multiple features should always be used, but the most important are shape, margins, and orientation for ultrasound. Don't just select one. Parallel or wider than taller is not always benign. Many cancers can also be parallel to the skin. So, the Lexington feature analysis of the masses. The big three include shape, orientation, and margins. Shape includes oval, including macrolobulated, round, or irregular. Orientation is parallel to the skin or not parallel to the skin. And margins include circumscribed or not circumscribed. We are now including in this section the echogenic rim. Under non-circumscribed, it's indistinct, microlobulated, angular, and spiculated. So masses can either be oval, round, or irregular. Or oval are when they're elliptical or egg-shaped. They may include 2 or 3 undulations, gently lobulated or macrolobulated. Round is when it's spherical, ball-shaped, circular, or globular. Irregular is when it's neither round nor oval. Here's a good example of an oval mass. It's two projections. Here's different cases, 3 different cases of a round mass. In both projections, the masses are round. Now, in this case, it's a papilloma. Here is a clot within a cyst. And here is a new metastatic lymphadenopathy. Irregular is when it's neither round or oval. And you can see here 3 different examples of irregular masses. Orientation. That's a property of masses unique to ultrasound. It's defined with a reference to the skin line. It's parallel, wider than taller. Orientation is a feature of some benign masses such as fibroadenomas, but can also be seen in carcinomas. Shape, orientation, and marginal characteristics should always dictate the assessment category. Here is a diagram of an oval shape in a mass that's oval but also oriented parallel to the skin. These are usually fibroadenomas, cysts, or sebaceous cysts, but they can also be seen in cancers. And here's an example of 2 ultrasound cases. Long axis of the lesions is aligned with the skin layer. It's horizontal or wider than taller. However, on your left side, you see the circumcised mass, which has the characteristics of a benign fibroadenoma. On your right, also a mass that's parallel to the skin, and also you can see that this patient had implants. The mass is just abutting the implant. But this mass is not it's not circumscribed, it's lobulated, it's irregular, and this was a cancer. Another irregular mass, which was parallel to the skin layers in both projections, and this was a cancer. What about masses that are not parallel to the skin? The anterior, posterior, or vertical dimensions is greater than the transverse or horizontal dimension, sometimes referred to as vertical, or taller than wider. Round masses are not parallel. Non-parallel masses can also be obliquely oriented. And here are 2 irregular masses which are not parallel to the skin layers. And these were 2 different types of infiltrate ductal carcinoma. And here is a diagram showing a round mass which is not parallel to the skin. And these usually referred to as cancers, but can be seen in cysts and abscesses. Margins, circumscribed or not circumscribed. The margin is the edge or the border of the lesion. Circumscribed means well-defined, smooth, distinct rim. And here you see it in a cyst. Non-circumscribed include indistinct, it can be either indistinct, angular, microlobulary, or spiculated. Angular is part of all margins have sharp corners or form acute angles, as in this case. In the perpendicular projection, you can see that there's angulation of the margins. Indistinct are poorly defined, and you can see here this hypoechoic mass, which you can't really delineate well. And this was an infiltrate ductal carcinoma too. Microlobulated, when there's greater than 3 small, short, cycle undulations, as in this case. These are perpendicular projections of the same mass, which was also a cancer. Spiculated. These are margins formed or characterized by sharp lines projecting in from the mass into the adjacent tissue. And this mass, you can see here, perpendicular projection, was a malignancy. We have now moved the echogenic halo rim to be part of the non-circumscribed margins. And the echogenic rim is not a sharp demarcation, when there's not a sharp demarcation between the mass and surrounding tissue. This can be seen in cancers and also in abscesses. Echo pattern. Well, it can be either anechoic, when there's no internal echoes, hyperechoic, when it's defined relative to the fat and equal to the fibroglandular tissue. Hypoechoic is defined also relative to the fat, and it's low-level echoes throughout. It can be seen in complicated cysts or fibroadenomas, usually. Anechoic, here's an example of a mass with no internal echoes, and this was a cyst. Hypoechoic, relative to the fat, low-level echoes throughout, and similar to the adjacent, or when compared, it's hypoechoic compared to the adjacent fat lobules. This can be seen in complicated cysts, seen in this case, of fibroadenomas. Hyperechoic is when it's homogeneously hyperechoic, defined relative to the fat. And here we see a hyperechoic mass relative to the fat. Now, when you correlate this with the mammogram, which a patient came in with a palpable mass, you can see that there was no solid mass here, but just a fat lobule. So this represented a lipoma in this patient who had a palpable mass, which was hyperechoic on ultrasound, and that on mammography it showed that it was fat density. Another patient which has a very fatty breast, when we did the ultrasound of the palpable abnormality, which there was an ill-defined density there, or ill-defined mass, we saw that the mass was hyperechoic compared to the adjacent fat lobules. In this case, because of the borders of the mass and on both the mammogram and ultrasound-guided core biopsy was done, and this was an infiltrate ductal carcinoma. Another patient, this was a hyperechoic mass. She presented with a palpable abnormality, and the hyperechoic mass was also very echogenic, or the borders were not well defined, was some shadowing, and this was a lymphoma. Echo pattern can also include isoechoic, when it's the same echogenicity as fat. Or it can be a complex cystic and solid mass combined, as in this example where there is a cystic area and also an echogenic area. And here is an example which can be correlated well with a mammogram in a patient with fat necrosis. Mixed hyper and hypoechoic echo pattern can be seen. That's when portion of the masses are hyperechoic to fat and portions are hypoechoic to the fat with no cystic component. What about posterior acoustic features? Well, there could be no posterior acoustic change, or there can be enhancement, increased posterior echoes, shadowing, decreased posterior echoes, excluding edge shadows, and this can be seen in 60% of the cancers. Or you could have combined pattern in which there is both shadowing and enhancement. Here are 3 different patients. On this one on your left, there is really no significant posterior acoustic features. On your right, you see that this mass that has a cystic and a solid component has prominent posterior acoustic enhancement. Shadowing is seen in this patient with regular mass with hypoechoic and shadowing posterior to it. And in this mass here, it seems like there may be both some posterior and some enhancement to it. Calcifications. Important to identify if they are not seen or if they are present. If they are present, are they macrocalcifications, larger than 0.5 millimeters, or are they microcalcifications, which are out of the mass, outside of the mass, or in the ducts or within a mass? Here is an ultrasound showing little calcifications within echogenic tissue in a patient with calcifications that were outside of a mass. And here you see nicely on the mammogram, magnified view shows a patient with ductal carcinoma in situ, and the calcifications were able to be identified with ultrasound. The importance of this is that if you can identify the calcifications on ultrasound, you can do the biopsy under ultrasound guidance, which is much easier, quicker for the patient than a stereotactic core biopsy. A different patient came in with a palpable mass, and here you see medial lateral light projection and craniocaudal view. Right in the area, there are some calcifications, and better seen here on ultrasound. You see the mass, and when the calcifications are within the mass, they're usually much easier to see. This is a mass that had cystic and solid components, and the calcifications were seen. Another patient in which calcifications were seen on the mammogram. Going back and looking under ultrasound to see that these calcifications were seen within this duct is, as I said, you're not going to change your decision if you're going to biopsy this because of what you see on ultrasound. You're going to make your decision on the morphology of them on the mammogram. But by visualizing them on ultrasound, you can certainly do the biopsy and sample them. We have a section on special cases. These include cysts, complicated cysts, clustered microcysts, intraductal mass in or on the skin, foreign body, lymph node, intramammary or axillary, male breast, post-breast conservation, fat necrosis, and including vascular abnormalities such as AV malformation, pseudoaneurysms, and Mondor's disease. And I'm going to show you a few examples of these. Here's an example, a clustered microcyst. And these are perpendicular projections, and you can see this is a mass with multiple tiny little cysts. Septations are thin. There are no solid components. It's very important to evaluate these carefully. Make sure there's not a solid component, because it's been shown that if you do see a solid component, you probably should biopsy these. If you do not see any solid component, there's septations, things like these things, septations. These are benign and don't even need to be followed. Intraductal masses. Here's a case that the panoramic imaging, a wide field of view, helped to show the extent of this intraductal mass, which was a papilloma. What about masses in the skin? Well, this is a magnified view, as you can see, of the two skin layers and the hypoechoic area between the two skin layers. You can see here within it, there is a mass, which is debris containing with a little peak. Very typical of a complicated sebaceous cyst. These sebaceous cysts, usually nothing needs to be done unless the patient is symptomatic, and sometimes we'll aspirate them for a relief of the pain. But another patient here also had a little mass adjacent to the skin, and we did a cone compression view, and we could see it was arising from the skin, and you can see on ultrasound that it's really it's seen between the two skin layers. However, this mass had a very irregular borders or margins, as you can see here, and because of that, it was cored, and this was an infiltrate ductal carcinoma. So make sure the margins are clear, are circumscribed. Also, in this section, it's including foreign bodies such as free silicone. Here you see echogenic material outside the implant, or postoperative scar, in which can be seen sometimes as a hypoechoic mass with shadowing and can simulate a cancer. However, you see this mass goes right into the skin, and there is disruption of the skin layer where the surgery was done. Lymph nodes. Lymph nodes are in this section. Here is abnormal lymph nodes, an asymmetrical thickening of this cortex is very suspicious for metastatic lymph node, metastatic cancer to the axillary lymph node. Lymph nodes can be very large. The size is not as important as the region of how much cortex is involved with is hypoechoic. In this case, this is a large echogenic lymph node. in the axilla and is completely normal. Adjacent to it, there was another one. And the reason is the hilum is completely filled with fatty tissue. These are two other normal appearing, sonographic appearing lymph nodes in the breast tissue. And these look like almost like kidneys. They have a hypoechoic cortex and an echogenic hilum, and flow can be seen going right into the hilum. In this section, we've included the male breast, and here is a male with a palpable left subareolar mass. You can see that there is an asymmetry between one side and the other side. We cone compress the view, and posterior to it, we did see some irregularity and increased flow in this patient who had gynecomastia. In these cases, sometimes you're forced to biopsy them if you're not sure you can make the diagnosis with the ultrasound and mammogram. Another patient came in here with a male with a palpable right subareolar mass. Now, you can see on the mammogram, the mass has irregular borders. There is retraction of the nipple, pulling by the mass. And on ultrasound, there was an irregular mass, hypoechoic, and this was an infiltrate ductal carcinoma. In this section, we also included fat necrosis, and here you can see on ultrasound the mass. If you did just an ultrasound on this patient who came in with a palpable abnormality, you would see an irregular, round, hypoechoic mass, which is suspicious for cancer. However, when you correlate it with a mammogram, you see that this is the region of the fat of the lumpectomy site, and she has developed fat necrosis. Mondor's disease. This is included in this section, in which you can see here a vessel. The patient came in with a palpable abnormality, and this was partially occluded, this vein. Another patient, also a very dilated, beaded-like appearance of a vein, which did not have any flow and even did not compress. And this was a Mondor's disease in two different patients. So at the end, we need to also, after evaluating mass, we need to be able to assess it. Is it negative? And give it a Birads 1. Is it benign? Give it Birads 2, such as a cyst or a fibroadenoma. Is it a probable benign? In this case, you may include fibroadenomas and you want a short interval follow-up. These are usually lesions that you think have less than 2% likelihood of malignancy. Or is it suspicious for malignancy? Greater than, we have divided now, Birads 4 has been divided into Birads 4A, which is 2 to 10% malignancy risk, or 4B, 11 to 50% risk of malignancy, or 4C, 51 to 95% risk of malignancy. Or is it Birads 5, in which there's highly suspicious for malignancy, greater than 95% likelihood? Or is it a patient that had already a known carcinoma and now is here for evaluation of another lesion? So in summary, check technical quality before attempting to interpret any imaging examination. Appreciate the importance of real-time observation. And in analyzing a lesion, use the feature analysis categories first: the shape, the margins, and the orientation. Descriptors within each category should also be included. Integrate ultrasound with other modalities in clinical data. Reach a conclusion, final assessment with a recommendation. Thank you.